fellowship in Toronto General Hospital. So his areas of specialization is advanced lung diseases, interstitial lung disease, and heart and lung transplant. Now over to Dr. Srinivas for the further academic program.
Good evening. Thank you for those kind words. And this is not my first time at IMA Erode. I'm very happy to be here this time, but talking on lung transplant. The aim of this talk was to introduce lung transplant to a general medical audience, to increase the awareness that this is an option for some of our patients, because at the moment we have several more donations than we have recipients. So that there are, and we have certainly a lot of deserving patients who are otherwise dying, who could definitely live a long, productive life with lung transplant. So the aim is to demystify, not to make it aware that this is not very complicated and it's possible to do this for a common lay person. Okay, so and the second component was what is the right time? That these are the two things I want to stress over the next 20 minutes. Okay. Slides are not moving. Next slide, please. So, why bother about a cadaveric program in lung transplant? Unlike kidney and liver, where they are fortunate to do a lot of the transplant. In fact, 90% of the transplant activity in kidney and liver is done using live donors. For lung and heart, we depend primarily on a cadaveric program. So, why bother about establishing a program, especially a lung program in India? Next, please. So, if you look at among the top, next, please. Among the top 5 causes of death, and this is data published in Lancet. So if you compare in 2016, what are the causes of death in India compared to 2005, if you look at the top 5 causes, what is evident is there are 3 causes which are respiratory, and this will be astonishing to a lot of us. That is, among the top 5 causes of death, 3 causes are respiratory. And if you look at the top 5 causes of death, there is only one cause which has increased in cause as a cause of mortality, that is COPD. In India, COPD is the second most common cause of death. And anybody who has traveled to Delhi in the last 1 year will soon agree that it will become number 1 as a cause of death in the very foreseeable future. And the effects of pollution take decades to mature. So what is happening now will be evident to us only 10 to 15 years later. So the side effects of what is happening now, we are going to see in the future. So the need for support services for all of this, in terms of chronic respiratory disease management, in terms of management for end-stage lung failure, is only going to increase. There is no way it is going to decrease in the foreseeable future. Another common problem is smoking as well in the community. So in most surveys, 30 to 40% of males smoke, and depending on the state, 2.5 to 30% of women smoke. So that is also another common problem, in addition to outdoor air pollution. Third most common problem is, of course, indoor air pollution. We all know the flagship program of the current BJP government, Pradhan Mantri, the scheme where they give LPG cylinders that is aimed at combating indoor air pollution due to using biomass fuel. Tamil Nadu long since there is a support program, so we are decades ahead of other states in terms of eliminating biomass fuel to a large extent. But the effects of that is non-elimination will take decades to mature. So we are still seeing patients who are exposed when they were children. It will take another 2-3 generations for that effect to go away. So all of this will be evident over the next few years. So this is why it is important. So if you look at what is the cause of mortality now, every year we lose about 833,000 patients to chronic respiratory disease. This is just COPD. This does not include end-stage disease due to tuberculosis, does not include ILDs, example, so many other respiratory diseases. All this captures is only COPD. So we are losing 833,000 people per year just due to COPD. And if you look at what is our population size in relation to the globe, we contribute about 18%. Next please. 18% of the global population, but we contribute to 32% of the global chronic respiratory disease mortality, indicating that we definitely need more options for these patients with chronic respiratory failure. Next please. So what exactly is the status of lung transplantation in India? Next please. So if you look at where all transplant activity has been reported, you can see vast majority of the country is white, meaning no transplant activity has ever happened in all of these states. And if you look at actually whether there is any significant transplant activity, on an ongoing basis, only 2 states report significant ongoing transplant activity. Next, please. So that is the state of Tamil Nadu, which of course is the pioneer in transplant program for the entire country. So the first heart lung, the first single lung, the first double lung, all of this was done in the state of Tamil Nadu, in the city of Chennai. And this is data consistently. No other state in India has such data going back to more than a decade. You can see the first single lung was started in around this time. So 2011, all of this was, before this was only heart lung. So starting from 2011, the program started, but actually you can see that the numbers really took off only in 2016-17, and COVID really played a break here. So we are now averaging about 60 transplants for the entire state now, currently. And the program from here migrated to Telangana. So there, where they are doing about 50 to 60 per year. So currently, these are the only states which are doing at least 50 per year. There are 3 centers in Tamil Nadu and 2 centers in Kerala doing transplants. There are satellite centers for these centers. So for the center at Secretaries operates in Mumbai, and the center in Chennai operates in Bangalore. So that is why these 2 states are represented. There are no independent centers at the moment operating independently in these 2 places. Jaslok has just recruited a surgeon, so maybe they will start a program. There has been a single transplant reported in Chandigarh. That patient died, and a few single transplants happened in Delhi, all of which have died. So really it is only Tamil Nadu and Telangana. Next please. Next. Next please. So, and if you look at why this is such a sad state of affairs, is unlike heart failure, the options for lung failure are very few. Even though this seems like there is a lot of options, if you actually look what changes people's lives, there are only 2 things. You can either offer symptomatic management for cough, breathlessness, in terms of oxygen rehabilitation, morphine, and end-stage, palliative care, or you can offer lung transplant. And a lot of these respiratory diseases affect end-stage lung disease, affect young people. So without much comorbidities. So it is very sad if you have to palliate these people. Next, please. And lung transplant, as is common, there is a common perception it's a very complicated thing and has very poor outcomes. But in our data that over the last cases that we have done of ambulatory patients who we have transplanted, we have at least a 90% survival at 1 year. Of the people who are surviving at the end of 1 year, over the next 5 years, 70% are expected to be. So we have, this data has not yet matured. Only we have this data matured because our program has started operating only for the last 18 months. So we are expecting, and majority, we still have, more than 85% of our ambulatory patients alive at this point. So we are hopeful that majority we will be able to keep alive for the next 5 years, and vast majority of this we are expecting them to be alive at the end of 10 years. So transplant does not come with an expiry date. These figures seem slightly lower than, say, liver figures, which is 10% better. But it's for an organ which is all the time open to the environment, it is not such a bad figure. And most of the patients that we transplant, we don't expect them to survive more than 2 years. So that is the other thing that you have to realize. So as opposed to a 60% 10-year survival, you would expect a 100% 2-year death rate for most of our patients with end-stage lung disease. Next, please. So the challenges in expanding lung transplant access in India primarily is physician acceptability, awareness, and of course then thereby your patient's awareness and in referral. The second most important is the timing of referral, which I will be focusing on for the rest of this talk. We are, of course, all of this is tied to cost, reimbursement and state support, and Tamil Nadu is again a pioneer in this, in the sense that we have a CM scheme for organ transplantation, wherein the state supports organ transplantation to a tune of 20 lakhs, including 5 lakhs for the first year medications. So we are able to do CM scheme transplant for a mass majority of our hearts. For lungs, because of the nature of the transplant being far more trickier than other organ transplants, we have a very rigorous selection program. Our criteria are published. So essentially we take people who are less than 50, who are able to walk 250 meters on oxygen, who don't have pulmonary hypertension, who don't have sensitization, who don't have prior surgery for transplant, and we can do that under CM scheme. So that is what we have done in the past, and we have currently operated our first patient under CM scheme. We are waiting, hopefully she will get discharged in the week to come. The other problems are, of course, donation rates and inequality, etc. And of course, there are a whole lot problems in cross-matching. Next, please. So, the next part of the slide is when to refer patients for lung transplant. It is not that we can transfer patients at any point during the course of respiratory failure. Next, please. As patients' lung disease worsens, next, please, they develop more advanced lung disease, chronic respiratory failure. Chronic respiratory failure will be punctuated by episodes of acute exacerbations, next please, which itself can cause advanced respiratory failure or, next please, lead to death. Next please. So as the disease progresses, next please, patients become increasingly frail and dependent on support for most of their day-to-day activities. Transplant is an option only for patients between a particular point. That is, they have to have sufficiently advanced lung disease, next please, for them to benefit from transplant in terms of both quality of life and survival. Next please. They should not be so debilitated that they cannot survive the surgery. So this is the transplant window. Anybody before this window, we would usually refer them back to the primary doctor saying that they're still too early, but we would like to follow them by measures of spirometry or radiological evaluation. At this point, we will evaluate them for a transplant, and within this window, we will list them and proceed with the transplant. Now, if they were to cross this window, then these patients would no longer be transplant candidates. That is, they are too sick to be surviving the transplant. So we would delist them. We would remove them from the transplant list until, for you, palliation is the only option. And we would, very, very few of these patients can actually come back into the list, either by doing rehabilitation or very selected patients, we can put ECMO and try. That is only for very young patients without much complications. Next, please. So what can you expect from a regular transplant? So this is a regular for India, but not necessarily a regular transplant in terms of what we can think. So for example, this is a 47-year-old Pujari who was on oxygen. So this patient was diagnosed as having pulmonary alveolar microlithiasis. That is a rare sporadic mutation in which the lung is replaced by lamellated calcium. So the lung becomes rock. So as over the decades lung fails, it does not proceed in the same rate for everybody, but in this patient it proceeded over a 10-year period. However, in between, so this guy was already on oxygen for 2 years and BiPAP for 1 year, and he was kind of lost to follow-up over this period. He had no PFTs done. By the time he saw us, he was so disabled that he was not able to go to toilet even with oxygen. So at this point, he was referred to for lung transplant evaluation. So the reason why he was lost to follow-up was primary focus was on the diabetes and coronary artery disease. So this patient was also a diabetic. He had MI, and with the MI he had a stent placed. He had mild LV dysfunction. So a lot of his management was focused on this rather than the respiratory failure, which was certainly aggravating his cardiac problems, because hypoxemia is not very good for people with heart disease. So when we saw him, there was another further complication in that he had a severe hypoxemia and he had an instant thrombosis 3 months before my current evaluation of this patient last year. So altogether, this is not somebody who you would think was a very good candidate, because this guy has had an MI in the 3 months of me seeing him. His LV function is only 47%. He's got osteoporosis, hardly able to even go to the toilet with oxygen. But otherwise, he's only 47 years old, good BMI. Again, 5 to 6 liters oxygen. So see the walking capacity, we would normally walk 400 meters at this age, but this guy is even not even able to walk 120 meters with oxygen. Next, please. So we quickly decided to complete the transplant evaluation. We primarily focused on the coronaries. We saw that the coronaries were pretty good and LV function was optimized and wedge pressures were okay. He only had mild to moderate pulmonary hypertension, and the rest of the workup was pretty good. So we vaccinated him and intensified the heart failure management and intensified OP rehab. We were able to double his walk distance at the end of a month. So at this point, we decided that he's a transplant candidate. We listed him for bilateral. So at this point, if we had not improved him, we would not consider him a viable transplant candidate. So we listed him. He got a lung at the end of, next please. At the end of 6 weeks after listing him, he got a lung transplant. So this is the X-ray leading on to the transplant. So he was continuously on 6 liters oxygen. You can see with this X-ray, he was on BiPAP for most of the day. And this is the intraoperative field. You can see the lung. It is looking like the liver. And this is the new transplanted lung, pink and well perfused on this side while being done on VA ECMO. You can see the explant, totally rock-like. Normally you'd expect the lung to be pink and collapsed when you remove it, but you can see this is not at all collapsing. It is looking like a rock, especially the upper lobes. A lot of calcified calcified. So if you look at the post-op, the only event that he really had was atrial fibrillation, which is pretty common. 50% of our patients have atrial fibrillation, which is usually managed with beta blockers and digoxin, very rarely amiodarone. So he did not require any transfusion. He was extubated on day 2 and tubes are out pretty quickly. He was out of the ICU by day 5, which was pretty good for him. And he was discharged home off oxygen on day 12. He has now completed 8 months and his FEV1 monitoring, his FEV1 is somewhere on 1.1 to 1.2 liters, which is pretty good for him. We are following him with he's still less than a year. We follow him with surveillance with BAL. We don't do biopsies because he's on aspirin. So all in all, a good outcome for somebody who was very, very rapidly worsening. So you can see the X-ray immediately post-transplant. This is the biopsy. This is on 10th day post-transplant. You can see no oxygen, able to do a lot of exercise. You can see him 8 months follow-up, put on a lot of weight compared to this. This is another recipient with bronchiectasis. Both of them came on the same day. So smiling, so all pretty good at this point. So we don't usually get patients without at least 2 contraindications for transplant. So if we are lucky, we are able to optimize them before transplant. A lot of patients we are unnecessarily having to turn down because they're being referred very late. So that is my message primarily. Also, it's important to realize that we have to wait for several months to get a good matching donor. During this, waitlist mortality can be as high as 20 to 30% because these people are already very sick. They're expected to die. That's why they are on a transplant list. So if the more ahead we are seeing patients, the better off we'll be able to plan their transplant. So what about transplant in India? What does transplant in India happen for? Next, please. So vast majority of the transplant in India happens for interstitial lung disease. This is data almost all from Tamil Nadu, 120 cases over 5 years. Another 10% happens for bronchiectasis. So vast majority of transplants are for interstitial lung disease. Next, please. So if you look at interstitial lung disease, especially the patients with UIP pattern, next please. How this is data from the largest cohort of ILD till date. Next please, the inbuilt trial. You can see that 12% will die and 50% will progress in 1.5 years after diagnosis, while on the best treatment we have till date. So it is important, and when we tell progression, we mean an FVC decline of 10%. So this is what we have to remember. The current statement which came out 2 months ago now declines progression by 5%, not 10%. So more 70% will progress by 15 months. So it is important to realize these are the patients who are going to die. So next please. So when would you refer patients with IPF or progressive lung disease? if the DLCO is less than 40, or if they have impaired lung function, or if they are declining rapidly, a relative decline in 10%. So if their FVC is only was initially 60%, if it came down to 57%, a relative decline would be important, not an absolute decline of 10%. So if it was 60%, if it declines by 6%, 54% if it comes to, then that is a relative decline. So 10% relative decline is important to trigger a transplant referral. Only then will we be able to catch these patients in time to save them. Similarly, in India, I think anybody when they start oxygen is a patient who's the right time to refer for transplant. So the other common indication that we see is COPD for transplant. Essentially, people who are having multiple exacerbations despite optimal medical management, who have pulmonary hypertension, who are using BiPAP and NIV at home, these are patients who are good candidates for transplant. Next, please. So this is data from COPD. Commonly, it is thought that COPD patients, it is better to be breathless, and they carry on for years and years. But if you look at the data from this is from the UNOS data from the US. This is compared with cohort who are not transplanted from the NET trial. You can see that the survival clearly is separate with the transplanted people much higher than the UNOS arm, even at 10 years. So showing that COPD also, transplant is a very good option for a vast majority of these patients. The other common indication we see is bronchiectasis, not so much cystic fibrosis. So for bronchiectasis patients, repeated exacerbations, pulmonary hypertension, and massive hemoptysis for whom you cannot do a resection, these are all good candidates for transplant. Pulmonary hypertension patients who are requiring prostacyclin, or who are worsening on double therapy, are patients who are good candidates for transplant, especially if they have early kidney disease, repeated syncope, or hemoptysis. Next, please. So this is again to re-stress, bronchiectasis, 10% of our transplants are for bronchiectasis, very common disease. If you see patients with bronchiectasis who are on oxygen or BiPAP, who are having pulmonary hypertension, very poor outcomes for these patients. These are patients who will benefit from transplant evaluation. Next, please. And for pulmonary hypertension, it's very important to pick these patients up because they have a very difficult and very complicated course, and they will very quickly worsen. So it's important to pick these patients up, especially if they are IPH or scleroderma pulmonary hypertension or CTD pulmonary hypertension. Next, please. And it's because the reason why we would like to see them early is because there are several, as you can see, this entire page is page of contraindications for transplant. So this is why we need to see them early. We need to see if they have any of these problems to pick them up. And all of this is in the handout that I've handed out. We don't want you to know all this. I'm just trying to show you that it's they have to go through all this to make sure that this is not there while going to a transplant, to give them a good outcome. And it's only possible if we see them early. Next, please. So how to access transplant, and this is my last slide. So if you have patients who have end-stage lung disease on oxygen and worsening, next please, who are able to walk independently with oxygen, and you feel medically that they won't die off over the next 3 months, then these are the patients who are good candidates for transplant. So please call me. My number is here, and several of you all have my number. If you don't have my number, please note my number, or you can always ask Uma, who has my number. And and you have a local expert who knows a lot about lung disease. So please take Dr. Uma Shankar's help as well. You have my coordinator's number here as well. So we typically would like to see the patient in person, but if a patient is an Erode, we don't mind seeing the patient by a Zoom call also. We counsel them, and if they're okay, the family usually moves to Chennai for a workup, where we typically admit the patient for 4 days. Now, if we admit the patient, then this workup is not covered by the cost of transplant. It costs 2.5 lakhs to complete the workup. The workup primarily involves screening for cancer, right heart catheterization, angiography, HLA, single antigen bead to look for sensitization, those kind of tests, microbiology tests, sputum cultures, AFB cultures, fungal cultures, those kind of things. For poor patients, we don't admit, we do ambulatory. We are able to cut the cost by 1 lakh, so it costs 1.2 to 1.3 lakhs to ambulatory do this. So depending on the financial status, we are able to tailor this for majority of the patient. Once we have the result and we have a plan, whether we are going to do a single lung transplant, bilateral transplant, heart lung transplant, lobar transplant, once we have a plan, or we are not going to do transplant. Once we have this plan, and the patient is agreeable to that plan, we will only list the patient if they agree to relocate to Chennai for 3 months, because we need patients to do rehabilitation for at least 4 weeks before going to a transplant. We will not transplant anybody who walks into us and tells, I want a transplant tomorrow. That cannot happen. We would like patients to do rehab to show that they are compliant, that they can follow these medications and protocol after a transplant, and they can improve their physical condition before a transplant for a vast majority of our patients. And typically transplant is done on an ambulatory basis. We don't admit patients leading into a transplant. The transplant surgery for a single lung takes 4 to 5 hours, for a double lung takes 8 to 10 hours. We are able to take the patient out of the ICU in an uncomplicated transplant by 3 to 5 days. For most majority of the patients by 2 weeks. We are able to discharge most of the patients by 3 weeks, 5% of our patients for longer than that. Typically follow patients after discharge for the first 3 months, every weekly for the first 6 weeks, and then every second weekly. At the end of 3 months, we are able to send the patient to where they were from originally. They're from Erode, they come back to Erode and follow up with the local pulmonologist who we are comfortable with, and then follow up for the first year at every 3 months. Beyond the first year, the management is general pulmonology. So they are able to manage with the local pulmonologist, and we usually only see the patient once a year to focus. We always follow the people every 3 months. We call them up and ask them about their immunosuppression level, blood tests and all that. So that will still happen lifelong. It's not that we finish the transplant, fill it, shut it, forget it. But for vast majority of the problems can be managed by the local pulmonologist, who we will be liaising throughout the life for the patient. So this is how we have done all our transplants till date. And it has helped me because I now have a lot of friends in my pulmonology circle who are now managing my patients. So this is my team, our program director, Dr. Kumud. You all know Dr. Sujit and me here, and our pulmonologists and our cardiologists, and most importantly our nurses and paramedical staff, our coordinators, all of and our support persons. Riaz, you met already here, who all make this.
Any questions from the audience?
So, Srinivas, it was a great presentation, and it was really an eye-opener for pulmonologists. Like, that whenever we see patients who are breathing on oxygen, we were all give sympathy only or empathy to them. Apart from that, I think this is an eye-opener for us, so that we can pick up the patient. And your message is very clear that it has to be identified very early. So my question is, in ILD, the percentage of FEC decline you have mentioned. So there is some difference between how the different kinds of ILD pattern behaves. For example, smoking-related UIP ILD behaves in entirely different way compared to NSIP, which is typically associated with the connective tissue disorder. So do you agree that this statement for fibrotic ILD, the rate of decline, is it same for all the ILDs, or it is different for UIP and it is different? Because the question is, many times patients with CTD associated connective tissue disorder ILD, is also they are reasonably dependent on oxygen, unlike smoking related ILD where the patient decline very fast. So what for a pulmonologist, what do you say that how to differentiate or identify in such cases?
Okay, this is a good question, and almost everybody in the pulmonology circle asks. The answer is, of course, you're always totally knowledgeable in hindsight, but that does not help you if the patient is dead already. So, in terms of UIP, we all know that UIP pattern has, irrespective of whether it's IPF or non-IPF, UIP pattern has accelerated lung function decline, and it's an independent marker of poor prognosis. So, leave apart UIP, we are speaking about non-UIP fibrotic ILDs. So non-fibrotic ILDs are not in this picture. Only for progressive fibrotic ILDs are in this picture. When you define progressive fibrotic ILDs, it means that they've already progressed. They have shown a decline in FVC over the last 1 year. They have declined in terms of their FVC already a relative at least 10%. according to earlier criteria. But now if you look at it, a 5% decline itself is taken as significant, right? We have now, internationally, we've all agreed that 5% decline in FVC is an independent marker of mortality. So we know that 12% are going to die in the first year. And our transplant mortality is less than that. So even at 1 year, you are going to give them a survival advantage, right? So that is the first thing. So we only select patients who are progressed. So that is why the referral criteria includes progression relative. So if you refer them at this point, it is not that they will be listed immediately. They will only be listed if there is an absolute 5% decline in their FVC with radiographic changes. So the FVC can be declined because they didn't do the PFT properly. So not only just the FVC, it should be there along with symptomatic worsening, radiographic worsening, and other markers. We all know those. So it's a multimodality assessment. So of course, the only time will tell. Who worsen faster, especially scleroderma patients will worsen faster compared to non-scleroderma patients. So you have to take an individual patient rather than a group of diseases. I hope I answered that.
I'm a nephrologist per se, so we deal with this rejections post-transplant. So what are the signs that you will take up for rejections, and as we do the kidney biopsies, will you do the lung biopsies as frequently?
Thank you so much, sir, for asking a transplant question. So for us, like, we have a very easy way to measure lung function. We ask for daily FEV1 monitoring. So every patient at discharge has a handheld spirometry machine that costs 8,000 rupees. So they are expected every day to do this twice a day. So religiously, for at least most patients do it definitely for the first 3 months. After that, they do at least once a day. So we always ask patients where your FEV1 is. After transplant, the FEV1 will go up as the lung remodels with the chest wall. For a single lung, this will usually plateau 6 months. For a double lung, it will plateau at 9 months. So usually it will keep on increasing till 9 months. So the baseline is the plateau. So if your lung value has plateaued at say 2.5 or 2.3 liter, that is your baseline. Any value less than 10% lower than this is taken as a trigger for rejection, infection, or whatever it is, for us to evaluate. So that is the first sign. We ask people not to look for symptoms. Please look at their FEV1 decline. So that is how we monitor patients. But if you ask for symptoms, we take any breathlessness, any fever, or any change, maybe like, in renal transplant, lung transplant also, very small occult signs can be signs of rejection. And we take all of those significant triggers, especially in relation to a FEV1 decline. And we have a very low threshold for doing a bronch and biopsy at that setting. Apart from this, we also follow a surveillance biopsy model for our patients for the first year. Beyond the first year, the incidence of ACR comes significantly low in lung population at least, and I'm sure the same is true for kidney. So, in the first year. So we typically do biopsies at 6 weeks, 3 months, 6 months, 9 months, and 12 months. So 5 biopsies over the first year. And beyond that, we don't do biopsies. We do a lavage at 18 months just to look for fungal infections and tuberculosis, but we do 5 biopsies, surveillance.
Induction immunosuppression?
Okay, so we don't typically induce, unlike kidney. More like liver, we don't normally induce. Induction has not been consistently shown to be beneficial in lung. We do give basiliximab 1 dose for some of our patients when we expect post-operative kidney issues to delay TAC, but we don't normally induce with 2 doses of basiliximab typically.
That was excellent presentation. Now I request Dr. Chakravarti, past president, to honor the speaker with a memento. But to be clear, on one perspective, out of all transplantations, kidney are the highest success rate, which enjoys around 95% success rate with the present immunosuppression. And more or less because of the COVID pneumonitis, patients have suffered a lot of irreversible lung damage. I think this is the point that the lung transplantations will start picking up in various centers. Now we'll go for the next speaker. Now Dr. Sujit V, consultant cardiothoracic surgery, heart and lung transplant surgery, and he has been heart and lung transplant surgeon to the Department of Kaveri Hospital in Chennai. He completed MBBS in Trivandrum Medical College and MS General Surgery in Trivandrum and MCH in Christian CMC Vellore and fellowship in adult cardiac surgery in Adelaide and fellowship in heart and lung transplant in Sydney. So his areas of specialization is heart and lung transplant and minimally invasive cardiac surgery, video assisted thoracic surgery and aortic surgery. With this small introduction, we will call upon Dr. Sujit to take over the dais for further proceedings.
Thank you, sir, for the introduction, and thank you all for giving us a platform to speak this evening. So, we'll just have an overview of heart transplantation and as to indications and contraindications. What happens in our country. So if we look at the history of heart transplants, so this was when it started in 1906 with some animal experiments. It was Dr. Alexis Carrel who who developed the technique of vascular anastomosis, and he did experiments on dogs and pigs. But as we all know, the first successful human transplant was by Christian Barnard in South Africa in 1967. But the third one, not many people are. And in our population, it manifests at least 10 years earlier compared to the West. This is the incidence of heart transplants worldwide, and you can see India So we are way behind compared to US and Canada and Australia. And this is the number of transplants worldwide every year. So most of it happens in North America and Europe, and the red portion is what happens in the rest of the world, including Asia. And heart transplants in India, annually around more than 200 to 300 transplants happen. And this is the figure in Tamil Nadu. So donations have gone up, but recently has come down. That's a black graph which shows the donors, and the red is the actual number of transplants as against donations. This is because of the reasons what Dr. Srinivas was elaborating, because of lack of referral at a good time and the waitlist mortality, and not all the donations are being utilized. So we'll come to the how to evaluate these patients and when to do the transplant. So these are the markers of advanced heart failure. So these are the markers as to when a patient should be referred for a heart transplant program. So whenever a patient is on recurring inotropic supports and NYHA 3 or 4 class, worsening end-organ functions like renal failure, early renal failure or hepatic dysfunction, low ejection fraction, and who are on AICD, who are getting multiple shocks, recurrent hospitalizations for heart failure, and having persistent pedal edema, needing escalations of diuretics, low blood pressure. So there's a mnemonic, I need help. And P stands for prognostic medications, in that we have already achieved the maximum dose of medications and they can no longer be optimized because of the blood pressure problem. We can't no longer increase the dosage of those medicines. This is when you need to consider them for a heart transplant. So the prognosis of advanced heart failure is bad in that 5-year mortality is as high as 50%. So we can no longer keep them under medical management. This is a time to refer them. So how to evaluate them? We do a cardio, in centers which have a machine like this is the best we can do. There's cardiopulmonary exercise tolerance, but not many centers have it. In those centers, we use the 6-minute walk distance, similar to lung transplant. So if we have a CPET machine, this is a more objective measure as to when this patient should be referred. There's a peak oxygen consumption. When it reaches that critical value of 12 to 14, that is when they should be referred for transplant. Or a 6-minute walk distance, if you don't have this. If they can't do a 6-minute walk distance at least around 300 meters, that's when they have to be referred for a transplant. And next important thing is to do a right heart cath, where we have to measure, we have to concentrate on 2 values. That's a TPG, transpulmonary gradient, and pulmonary vascular resistance. These are the 2 numbers we are interested in when we evaluate anybody for heart transplant. So anybody with a high transpulmonary gradient or high pulmonary vascular resistance cannot be considered for heart transplant alone because the donor heart will fail with those elevated pulmonary pressures. So then they have to be reevaluated, and whether they are transplants for heart lung, they are candidates for heart lung transplant, we need to evaluate. So this is not a fixed number. Right heart catheterization has to be repeated at 3 to 6 months interval, because these numbers keep on varying, and they have to be kept on optimal medical management. So overall, these are the indications to refer for a heart transplant. So as we discussed, NYHA 3 heart failure, despite your optimal medical management, more than 1 unplanned hospitalization for advanced heart failure in the past 1 year, impaired exercise capacity, we already discussed, and repetitive shocks in the patients with AICD or uncontrolled malignant ventricular arrhythmias. These are the classical indications to be followed on to when to refer for a heart transplant. So broadly speaking, these are the contraindications, of which more than 70% we can attribute it to cardiomyopathies. This can be ischemic or dilated or restrictive cardiomyopathies. And refractory heart failure with NYHA 4 symptoms, intractable arrhythmias. Sometimes we get congenital heart diseases in an advanced stage where we can't do any surgical correction. In those cases also, we consider them for heart transplant. Then there are miscellaneous causes, and the last one is an indication for a retransplant. When somebody has undergone a heart transplant and they develop chronic rejection in the form of cardiac allograft vasculopathy, and if they are suitable, we consider them for a retransplant. Contraindications are the same as for any solid organ transplant, except for the most specific contraindication is irreversible pulmonary hypertension, which we already discussed, wherein the donor heart will fail with the high pulmonary pressures. So any pulmonary vascular resistance more than 4 Wood units is an absolute contraindication. Rest of the contraindications we are all aware of. Workup is pretty standard as for all transplants. Donor-recipient matching. We have a formula for predicted heart mass calculation. It depends on these factors of both donor and recipient. And ABO match, of course, and some immunological tests are also conducted. So, surgical technique. So, we have 2 techniques, biatrial or bicaval. So, biatrial is when we expose these atrial cuffs. This is a left side picture showing the excised donor heart with those cuffs left in place. Left atrial and right atrial cuffs are left in place. And the aorta and pulmonary artery are transected, and the new heart gets sutured to these cuffs actually. So that's a biatrial, atrium to atrium suturing, or it can be a bicaval. This is what is most commonly done, where we excise the right atrium completely, and SVC and IVC are separated, and left atrial cuff is left in place, and aorta and pulmonary artery. So 5 anastomosis instead of 4 anastomosis, bicaval. This is so standard. What we do is a donation after brain death, where the heart is still beating. That's called a DBD. Where this is a DCD heart. This is usually not done in India. This is done abroad, wherein the heart has stopped beating. This is a circulatory death. Heart has stopped, and we retrieve it and put it on a special machine. And this is similar to heart-lung machine. We supply oxygenated blood and make it beat and reassess it in over 4 to 6 hours. This is entirely different concept. It's not practiced in India. This is just for completion sake I had put this. And immunosuppression as standard immunosuppression for any solid organ transplant. So these are the complications we expect following the transplant. Primary graft dysfunction, rejections and infections, and adverse effects of immunosuppression and chronic rejection, which is known as a cardiac allograft vasculopathy. It can be as high as 50% at the end of 10 years. So we usually follow them up with endomyocardial biopsy. We usually don't do because of the high cost and the complications involved. So for us, the feasible technique is echo and coronary angiography. We do annual coronary angiograms to check for any cardiac allograft vasculopathy. And some recent advances, in order to match, because of the donor shortage over the recent years, we have extended the criteria. We have extended the criteria for donors. We have been practicing to take the donors' hearts even more around 50 to 55 years. Also, we accept sometimes. And those with the left ventricular hypertrophy, which is always a contraindication, we can select it for some patients. And DCD heart was already discussed, but it's not yet started in India. This is all to expand the donor pool and tests that can replace endomyocardial biopsy. These are all in the developing stage actually. Prognosis, heart transplant has got a very good prognosis, similar to maybe second organs after kidney. 1 year survival is as high as 90%, and median survival is as high as 13 to 14 years. So conditional survival, those are the graphs. So when somebody the conditional survival of 1 year survival, they can expect to survive even 13 to 14 years after a heart transplant. So this should be compared with the prognosis of advanced heart failure, which we saw earlier, where 5-year mortality is around 50%. We have 13 to 14 year survival for a well-selected patient who is referred at a good time. So that completes my presentation. Thank you.
So today, Erode IMA has witnessed all transplantations related talks. So in deceased criteria donor carrying wait list is as all when compared to kidney, the routine protocols are followed, or in hospital will get a heart, and is it like that, the harvesting hospital?
No, you mean the DBD? Yeah.
So after brain death, donation after brain death,
Yes.
if it happens, suppose if there is a donor in some hospital
Yeah.
that has a heart transplantation by themselves, then the in-house will get priority, and how is it going to the pool?
In-house, yes. Exactly. Yeah.
The induction immunosuppression is used in this?
Yeah, as Dr. Srini was telling for the lung, we use basiliximab. Again, depends. At the most, we usually use only basiliximab.
Of both this heart and lung, you go for ABO match routine?
Same again rules. ABO identical is first. If the hospital doesn't have an ABO identical, they are allowed ABO compatible. If they don't have a ABO compatible, it goes to the pool. So we do ABO compatible. We don't do ABO mismatch at all.
ABO incompatible is not.
Incompatible we don't. Only kidney guys do. And of course the liver guys do. Yeah.
And any utilization for HLA matchings?
So HLA in a cadaveric program, in real life we can never match, right?
In live program?
Live we don't have heart and lungs. So yeah, so we don't have it.
Any questions from the floor?
Sir, like for a lung transplant, unlike a renal transplant, the organ has to fit into the thoracic cavity. So some patients might be very small, the donor might be very tall. So how do you assess that whether this lung can be transplanted into this thoracic cavity? Is that any assessment is there?
Of course, both for heart and lung, this is an important thing. For heart, like he pointed out, the predicted heart mass is very important because, like Dr. Kumud likes to say, you cannot put a Maruti engine into a Fortuner. So, similarly, for the lung, it's like the brain because it has a fixed space in the thoracic cavity. There are significant problems if you undersize and oversize. If you oversize, you won't be able to close the thoracic cavity. If you close, you will compress the heart. So you will impair RV filling and patient will go to failure post-operative. Right? Hemodynamics will immediately suffer. Patient will crash on table. If you undersize, you will have size issues. You'll have persistent fluid collections, repeated taps, empyema. You'll have more PGD. All these problems will be there. So sizing is an important problem. Now, the usual rule is if we don't do gender matching, we do male, we take male to female. So on a given height, a male is typically 10 to 15% higher. So 10 to 15% is allowed. Up to 15% you will be able to put it in without issues. So we can take the same height irrespective of the gender. That is for all patients. So we use height for a matching. But worldwide, if you look how they match for lung, they use what is called a PTLC, predicted TLC. So that is again primarily based on gender and height. So these are the two variables because obviously gender also has a relation to lung volume. But what it does not include is the disease. So a significant problem happens in ILD patients and in COVID fibrosis and ARDS patients in whom there is a significant volume shrinkage. So for a given height, the lungs are not as tall as it was before. So there is no real way to use this because we actually need actual TLC to match, which most of the patients won't even have a single PFT done, forget TLC done. So here you have to go by certain other measures. We use, for example, X-ray heights, and we use our
Biopsies in heart is endomyocardial or?
Endomyocardial.
It's endomyocardial.
It has to be.
And any signs that is for post-transplant rejection indicators?
Projection, it is
CKMB, anything like that? CKMBs?
Those are there. Markers, we usually follow echo. Diastolic dysfunction will be the first sign. Those enzymes are non-specific. We can't absolutely rely on them. Endomyocardial biopsies are not routinely done because of the cost involved and of course the risk involved. So
post-transplant immunosuppression will be continued for lifelong?
Yes, lifelong. Steroids up to 1 year and like other protocols. Yes.
Mycophenolate and tacrolimus. And trough levels that you maintain for tacrolimus will be?
It's the same as
3 to 7.
6 to 8. Six to 8. Here.
Higher levels than what we are. We only target 10 to 12. Usually our target drops at 6 months. So we don't have long-term issues related to that because our target is significantly lower. Having said that, chronic kidney disease in long-term survivors is a significant problem. 12 to 15% will have some chronic kidney disease at the end of 10 years. But then you are really happy that a patient has survived 10 years, and most of the time they don't need any support. Only 2% will require dialysis or transplant at the end of 10 years.
mTOR inhibitors in immunosuppression?
So mTOR we cannot do initial 3 months because of wound healing issues. Now in lung we have a problem because mTOR inhibitors have association with ILD, which can be interstitial immunity, which can be life-threatening and irreversible. So we don't like to try sirolimus or everolimus in lung. But we do try sirolimus or everolimus if there is a post-transplant lymphoproliferative disease, when we would like to go off
I think
there.
sirolimus can produce reversible because one patient I had in
The problem is
interstitial
it's difficult to predict if it can be reversible or not. You pick it up and
sudden
you stop
stoppage
it,
of drug.
but suddenly it can progress. Other problem is 15% can have pulmonary embolism with mTOR inhibitors. That is another complication which we don't like. But heart people use far more mTOR inhibitors than we do. Yeah. Right.
So now I request Dr. Masalamani to honor the speaker with a memento. I also request the first speaker also to join us for the stage.
Thanks sir, for all the questions. So nice.
Every month, Kaveri Nature Cure Center will give deep relaxation technique and reflexology. Previously, we were doing it before COVID. Now we have started from this month. Maybe next month onwards, evening 5 to 6 o'clock, we'll have in this main floor and first floor also reflexology. Now I call upon Dr. Suresh to give us some.
Good evening to all the doctors. I'm Dr. Sudarshan, Care Center, Tirkupalayam. So I'm basically so currently I'm working at Kaveri Nature Cure. So I'm here to give a short, brief note on naturopathy. So naturopathy is a system, holistic system of medicine, where it treats mind, body, and soul. That is why we call this system as a holistic approach. And the main key of this naturopathy is that we treat the root cause, address the disease to the root cause. I think by removing the root cause, we can treat any diseases. We also believe that naturopathy, body heals itself, which means body has its own recuperative power to heal the disease. We just have to give the right time and right environment to treat the body. That is the basic principle we work on. And we've been doing DRT session and reflexology in IMA before Corona period. And now we have planned to continue it again. And I would like to give a short brief on DRT also. And I hope all of the doctors in here are very busy, and hopefully stress is a part of life today. And coping up with stress, are we doing it really right? I don't think most of us give right time for our mental healing or to mental rejuvenation. So I think DRT is that one thing you need to give your mind the breathing or the enough time to recuperate itself. So DRT is proven meditation, a kind of meditation relaxation technique. where it calms your mind, sedates your body, and it gives time for your body to heal. And it basically calms your mind through acting on autonomic nervous system. And during the 40 minutes of the session, it is proven that your parasympathetic activity is being increased. So in this DRT session, one will be concentrating both on the physical and mental, which means like, for instance, if I ask you how many times you breathe in a minute, nobody knows. But whereas in DRT, we will be asking you to concentrate on your breathing and your body. And when you do so, you can have a very good control on your breathing. And when you take good control of your breathing, yoga says that kumbhaha, there is a word called kumbhaha, which means cessation of breathing. For example, I would like to bring a small example. I mean, most of the women might know this. When they needle a cloth or they stitch a cloth, they put the thread inside the needle. There is a very small hole, and you have to be very careful. You have to concentrate in that minute hole to get this thread into that needle. So during that time, if you note, for the next time, if the women or even gents, if you're trying to do that, if you note yourself, you would pause the breathing. You're stopping your breathing for a second to get that concentration. That is where yoga is acting, and that is what yoga does to your body, giving a breather to your mind and body. That is the basic of this relaxation technique, and I hope everybody would want to know about this session more. I think due to the busy schedule, we were not able to do this time, and Sunday, from Kaveri would conduct DRT as well as reflexology. And coming to reflexology, I think this is one another very good treatment for completely relaxing your body and mind. So how does this reflexology act? So we all know that we stand, sit, we use our soul and foot most of the day. Like in 24 hours, I think most of the day we work. At least for 12 hours, at least 50% of the day we used to work. We use our legs heavily. So, and we all know that the nerve endings, the nerves are ending at the soul, most of the nerves. So traditional technique, Indian technique as well as Chinese says that when we stimulate these nerve endings, each of these nerve endings are like a root of a tree where it connects to each organs. For instance, there is a kidney point in your foot, there is an eye point in your foot, there is a liver point in your foot, which when softly stimulated will sedate that particular organ. I mean, not sedate, it tones that particular organ. By toning, I mean the proper circulation is sent to that particular organ, where the organs will be efficiently working to eliminate whatever toxins it has, and it will get time to heal itself. That is the basic principle behind this reflexology, and I hope doctors would like to enjoy this reflexology. And we have conducted reflexology like 1 hour ago. I hope most of the doctors were busy in this meeting. We could not also manage with the time. From next month onwards, we are planning to go with DRT and reflexology. I mean, deep relaxation technique and reflexology. I hope every doctors would want to enjoy it. I kindly request all the doctors to participate and know more about this technique by experience. And Kaveri Nature Cure is a 100-bedded hospital. It is at Tirkupalayam. So we do conduct kids yoga session every weekend, 5 to 6 p.m. And we also do regular yoga sessions for women, men. Individualized yoga sessions have been going, and we also treat a number of lifestyle disorders, and as well as post-operative cases, and pain management also has been done in our hospital. So thank you for giving me this opportunity. I thank the President and the Secretary for giving me this time. Hope you understood a little bit of naturopathy. To learn more, stay tuned with us, and hope I'll meet you by next session. Thank you, sir. I thank Dr. Masanamani also for giving me this chance. Thank you, sir. Thank you, doctors.
So from next month onwards, we will also have this reflexology session for before the start of this session. Now we will go to the Secretaries Report. We will see what are the activities that Erode IMA has completed. On April 18th, we had a monthly CME meeting, and that was successfully concluded. And Thangam Hospital has participated in the as academic sponsor, and Dr. Sridhar and Dr. Deepthi has given the talks on various subjects. And World Earth Day was conducted, and plantation of trees was completed in primary school center. And this is the event, and this was conducted on 22 of April, and this was conducted in Teachers Colony, Erode. And then comes the noise pollution and World Malaria Day awareness rally was conducted, and the rally has started from the Kalingarayan place, and it was concluded at the Erode IMA Trust building. And finishing the rally, the press meet was conducted, and noise awareness producing speech was given by the senior IMA members and the office bearers of Erode IMA to the press meet. And on the same day, World Malaria Day was also coincided, and some of the hoardings about the World Malaria Day was also added on. And this is the pledge that all the IMA members have taken up about the awareness about noise pollution and malaria awareness. So this is the International Nurses Day, and we have participated in the International Nurses Day in Erode Government Hospital with the help of JD Assistant Dr. Venkatesh and Dr. Gomati JD, and nurses was given mementos on the International Nurses Day. So this is the events that the Erode IMA has completed over the past 1 month, and we will go for the vote of thanks by Treasurer.
Good evening, one and all. We have come to the end of the program. I thank both the guest speakers and also the grant given by the Kaveri team and M&W Life Sciences. I also thank the audiovisual team and other supporting staffs. Please join us for the dinner. Thank you.
We'll proceed for the national.